Welcome to PCOM Perspectives, where we discuss news, events, research, and other topics impacting our campuses and communities. Join us as we share our PCOM perspectives. Hello, and thank you for joining us. I'm your host, Dr. Jay Feldstein, and today we're talking with Dr. Fred Goldstein, Professor of Clinical Pharmacology in the Department of Biomedical Sciences at PCOM. Dr. Goldstein has been teaching at PCOM for over 30 years and has conducted extensive research examining the use of drugs to reduce pain in postoperative patients. His current studies focus on increasing analgesia in those with chronic neuropathic pain using THC or a THC CBD combination. In addition to his work at PCOM, Dr. Goldstein serves on the editorial board of the Journal of Opioid Management and has been an active member of the National Board of Osteopathic Medical Examiners. Today, Dr. Goldstein and I will discuss how pharmacology education has evolved over the years and how substance abuse and artificial intelligence impact the way we teach it. Welcome, Fred.
Thank you, Jay.
It's a pleasure to have you here today. I know you've been looking forward to this, and so have I. So I've got a couple of questions for you. So my first one is, in what ways have you seen the teaching of pharmacology and drug-related topics transform throughout your 3 decades as an educator?
So how many hours do we have?
Not enough.
I decided to split into 2 parts, mechanical changes and actually clinical pharmacology information. So the first part with mechanical changes, when I started teaching, I had a very important piece of equipment. It was a piece of chalk. Okay. And I wrote on the board and students took notes, and that's basically how we taught. As things advanced, we decided to give the students printed notes, so that they didn't have to write everything and they could make some comments on the side. So that was a pretty good advance. The next one was PowerPoint slides, which really is significant and great, because you can take a PowerPoint, you can add some figures, you can add whatever you want. And as long as you get it done about a week before the class, you can make some changes. So that was a great advance. So we don't use chalk anymore, we're electronic. The next one, and we can talk about that a little bit down the road, is the involvement of AI. And that's a little more complicated, and I do have some thoughts, but I'd rather hold off for a little further down. So then the other part of changing is the clinical pharmacology information. And when I start teaching, I tell the students that when I was in grad school, I knew everything about drugs backwards and forwards, and they're wondering, why is he bragging about this? And then I say, the reason I knew everything about all the drugs is when I was in grad school, there was only 4 drugs. Some of the students laugh.
You can say kids. Most of them are kids for us.
I don't want to insult anybody. Some of them, look like, really? And that's a joke. Most of them do get it. So we've had a significant increase in a number of FDA-approved drugs. I've written 4 papers on this in the last couple of years. And from 93, when I got here, to about 2022, there were 1,000 new FDA-approved drugs. Okay. And there were more details of mechanisms of action, subcellular, that were more than when you were trained as a doc and when I was teaching, which was before you. There's also increases in almost every other med school topic, including biochemistry. And we've had an addition of immunology, which barely existed when we started. My decision as a pharmacologist is, how do I teach the information properly so a physician has enough information to properly treat patients effectively and safely? And with all this explosion in information, and there was no, as we all know, there's no increase in time. It's still 2 years. Right. Going back to the Flexion report.
It's also a lifetime, right? You want to teach them how to evaluate these drugs over the course of their careers, because we're students forever.
Exactly right. And I do talk about clinical research, but for my decision is, how deep do we go at a subcellular level? And I've made a decision that, and talking to my physician colleagues, that I don't think it's necessary to go down to the deep level, because the amount of information is huge. And I think we would be punishing students. So where I stop, for the most part, is at the receptor level.
Okay.
And I make the point that receptors are physiologic. They're not there for drugs, they're there for physiology. And if you know what a receptor does, Then you have the drug, and the drug either activates the receptor and makes the heart go faster, or blocks the receptor and slows it down. That's the major connection. We do not have drugs that cause the heart to make urine. Drugs just increase or decrease physiologic effects. So from my perspective, if a doctor knows which receptors are going to be activated or blocked, then he or she knows the pharmacology of the drug.
Makes sense.
And that's how I approach it. Now, there are other data, for example, half-lives. And it's not relevant to have students memorize all these half-lives, although I do distinguish long and short-acting. But I presented to the board officially this summer to the National Osteopathic Board my proposal to have in the exam an electronic unit that they could get into, which will have the half-lives and drug interactions there, just like a doctor does in the office. And I tested this on 10 students, and it worked pretty well.
So did they adopt it?
I didn't hear back yet.
Okay.
I didn't hear back yet. But my point is that this is relevant to how doctors run their offices anyway. And it's important information. How frequently should a patient, take a drug? Well, what's the half-life?
Right.
If the half-life is 24 hours, they could take it once a day. So those are the issues that I have proposed, and in trying to deal with modern teaching of pharmacology.
Sounds very reasonable. My second question, I know this is really kind of your area of expertise, is how do you integrate substance abuse education into your pharmacology curriculum to ensure students understand both the scientific principles and the real-world impact of drug misuse?
Yeah, I'll use an example of opioids. I teach opioids to the med students. It's in year one. And I go over the basic pharmacology, adverse reactions, mechanism of action. I do go a little bit subcellular because for these drugs, it's pretty important. What are the drugs used for? Mostly for pain. What are the adverse reactions? What are the drug interactions? And how I integrate it is at the start, I show them a video of a 14-year-old patient who's terminal, who was in terrible pain. And basically, he was taking a lot of drugs for his liver problem, and he wanted to stop. And the doctor said he couldn't. It really was pretty intense. But I showed them this young boy crying, again in pain, who passed. And that's before I mentioned anything about opioids. Just to start, when you ask about clinical, I want them to get into their head, this is a serious issue. And if it's not treated properly, there's problems. So I go through the basics, and at the end, I show them one of my post-op patients who had cervical fusion. We used preemptive analgesia, injection of morphine before they started surgery, and after, and he had basically no pain. And that's at the end. And I said, that's the goal. You can't always achieve that because for some patients who are terminal, I do have experience in treating terminal patients with doctors. Most patients, in my experience, do not want to be obtunded at the end. They want to be able to communicate with their families. So they're willing to deal with a certain amount of pain. So now where it gets into the substance abuse is that there are already cases of doctors withholding pain meds because they don't understand the deal. They're afraid of causing their patients to become addicted. That's not going to happen. One of my comments when I start talking about this topic is fentanyl is a good drug. And I go on to explain why it's a good drug. And I go on to explain that most people who get it do not develop an addiction, just like with alcohol. About 10% of people have an alcohol use problem of all the people who use it. What about the other 90%? So addiction is a serious problem. And I differentiate that from physical dependence. A cancer patient whose cancer is metastasizing is probably going to need more opioid. That's not the same thing as a person with an addiction. So addiction is a serious problem. In that realm, I created a word called suicidogen. There's carcinogen causing cancer. Based on my work, I've dealt with several patients who really wanted suicide because of the pain.
Really?
Yes. So I created the word suicidogen, which if you look it up in the internet, it's there. It's identified as a new word. And I have my papers. So that's where I try to bring in the aspect to the future docs that you need to treat the pain. And there are ways that you can tell about addiction. They're trained, and when they do their H&P, they know how to kind of look for that. Does a person have a problem with alcohol? Do they have a steady job? I mean, there's things that I don't have to tell the docs. So it is very important. I try to bring it in as much as I can. And the students understand that I do have clinical experience. Again, I'm not a physician, but I work with physicians in consulting them. So I think they respect what I bring in.
All right. Well, it's, you got a real world perspective there, which I'm sure they appreciate. So today wouldn't be complete if we didn't talk about the wonder drug of 2025 and the GLP-1s. It's all about weight loss, but now it's for every condition under the sun. And I was curious, do you see a role for GLP-1s in addiction treatment?
Yes.
Okay.
It's an amazing find. I'll just tell you, in general, there needs to be more clinical studies. Okay, they've done a lot of animal studies, and it comes down to how's it working? And there's information on both sides, but more of it seems to be that it's a dopamine releasing agent. And every addiction causes this feel-good neurotransmitter to be released, as you probably know. So whether it's shopping or gambling or sex or internet or even tanning addictions, it's this charge that they get, which makes them feel really euphoric. And the belief is it's probably dopamine being released. So there's a pretty good connection that it's with dopamine. Now, would this work for other areas? Again, there's some evidence that it would. There's a number of animal studies where they can reduce the animal's drug-seeking behavior when they get these drugs. So in adults, some of them feel it happened. Now, the most significant information came in folks who had an alcohol use disorder and had obesity. That was the most meaningful results to date, where they reduced their alcohol use. So there are studies underway to look at reducing opioid use. And yeah, if this drug holds up in clinical trials, I think it would be great, because we wouldn't have to use methadone or buprenorphine or some of the drugs that we use for alcohol use.
Are they running any of those trials?
Yes.
Are they ongoing
yes.
now? I was really curious about that.
This is very active. It's a very active area of research. Absolutely. In fact, one of the drug treatment centers not far from here, their doctors are using that for their addiction patients on drugs. So yeah, it looks like a potentially great drug, but as we all know, there are some side effects. And nausea, vomiting, diarrhea is pretty big. I just read a paper that there's just came out a chronic cough associated with these drugs. There's the work to be done, but it's not risk-free.
Well, no drug is. We know that.
Yep.
And I share your concerns, and I also worry, as more and more people use these drugs, we're going to see more and more side effects.
Right.
We just are.
Right.
And it just gets back to the old risk-reward ratio of medicine.
Right. And there is some evidence of some tachycardia, some cardiac effects as well. So yeah, you're right. But it really takes a controlled trial. And it's not like the ads on TV where somebody takes a drug and they say, I feel great. Okay, that could be a placebo. So the controlled is there's placebo involved. It's random entry of patients. It's very much controlled, so that and random entries, so that we already know from patients 1 to 100 who's going to get the drug and who's going to get placebo. So you've got to run it against placebo. And those large scale studies have not yet been run.
Are you thinking about doing any of those studies in concert with any other, schools or?
I have not yet, but we have a very fertile area of research topics that some of us talk about. So that is something, if there's some physicians involved, yeah, that's something that definitely would interest me.
Okay. All right. Well, I'm sure you got a couple questions for me, so I'll turn it over to you, Fred, and we can trade places.
Okay. The first one is, and I have a little preface for this. What led you to your decision to move into medical marijuana research? And I just want to add that I thank you for your interest. Many years ago, you asked me to go to a meeting at Einstein to talk about the possibility of marijuana for research. So if it was not for you, I wouldn't have been doing this. We wouldn't have a large grant from Organic Remedies. So what led you to get into this?
Well, I was interested in the medicinal qualities of THC. Marinol was the only one that was FDA approved for nausea for chemo.
Right.
And, it was a burgeoning field. I was always trying to increase our research opportunities here. And we had a willing partner, and it just seemed like it made sense. We could more research opportunities for faculty, more research opportunities for students. And at the end of the day, more research opportunities to improve patient care and patient outcomes.
My case, there have been benefits. I'm using it for neuropathic pain. There's been a reduction in neuropathic pain, which does not respond, as you know, that well to opioids or to gabapentin, particularly.
Right.
So it's working. We're getting effects. There's benefits. And I know that several other colleagues, like Dr. Michelle Lent, is getting some good results from her study. So yeah, it has opened the door for a lot of us to do research. And again, I thank you.
And I think for Pennsylvania, one of the things that I think is continuing to drive the medical cannabis research is we haven't gone to recreational use yet in Pennsylvania. So I think the companies, if they want to continue to stay in business, are going to need to continue to fund the research. Whereas other states that have recreational cannabis legalized, I think there's a drop-off in cannabis research in those states. I don't have the exact data, but I think a lot of them, it falls off because the companies aren't required to do the cannabis research.
Right. And I want to sort of in view of that, they've been cracking down on some of these stores that are selling marijuana because they found out that the concentrations are much higher. They're not supposed to have more than 0.4% THC, so they can sell CBD in a mall.
Right.
But they have found out through the state that some of them have 100 milligrams of THC, way, way over the limit. So they're shutting those down, which would help the dispensaries.
No, agreed. And it will help perpetuate the research because I think there is tons of opportunity for more research.
Yes, absolutely agree. It's safer. There are issues. There is evidence of CAD, coronary artery disease, coming up, showing that can occur in patients. There are effects on the immune system. There's data showing women who use it during pregnancy, their offspring at 9 to 11 years have some psychopathological issues. So it's not a completely safe product.
No drug is.
Right, but I mean, but I don't want to oversell and
right.
say that the safety from a death standpoint is safer.
Right.
But there are other issues.
Agreed.
So the last question I have is, and this is one that I kind of mentioned earlier, we can discuss it, but how do you see the use of AI impacting the future of PCOM's medical school curriculum?
How much time do we have?
You're the boss.
From my perspective, you can't look at it just in isolation of a medical school curriculum. It's the overall impact on healthcare, period. I mean, it's going to impact the practice of medicine. It's going to impact the medical school curriculum. I think there's different levels of AI. And from my perspective, the first place I like to start for us is I think every student should have the ability to have an AI tutor where you could have AI tailored to an individual student's learning capacity. How do they learn? Are they visual learners? Are they auditory? Are they sensory? Whatever it is. And then, through, question and answer periods, how they do on quizzes, how they do on tests, they can supplement themselves in addition to using faculty. So I think that's a great tool that we, need to explore. And we're in the process of exploring that. I like to get to the point where we figure out what's the best, say, chat in quotes, GPT tool that's the safest, that uses our own data internally. And how do we make that available to everybody, students, faculty, staff, so that we maximize its use for the learning environment? I think it's a great way to help people do research. You can do tremendous literature researches. It can help with writing papers. It can help with grants. It can help with design of lectures. Not to say that you're going to design a lecture for each individual student, but you could see a time where that could actually be created, where you could put a template out and a student can then, this takes it a step beyond the tutoring, creates that lecture in a format that they can learn the material the best. I see it as a tool. I really don't see it as replacing anyone or anybody. It's just a tool. Just remember how the internet was going to change the world. It did, but not in ways we expected.
Yeah.
Right? I mean, not in ways we expected. You and I grew up with the Encyclopedia Britannica to do our research. We went to the library to do our research. Your research is done in 15 seconds now.
There's no doubt about it.
And it's a way to help to keep up, quite frankly. I mean, there's so much information, that's doubling like every year. It's almost impossible to stay up. And this will be a tool, I think, to help people to stay current. Right. So I think you'll see it at every level. You'll see it in the didactic curriculum the first 2 years. You'll see it in the clinical years. It'll be integrated into simulation. Help students think about a differential diagnosis. It's going to help physicians think about differential diagnoses. And it'll really help in the administrative war between insurers, payers, and providers.
In terms of note taking, that it saves doctors. Okay. My concern is the control. You've heard about AI hallucinations.
Oh, without a doubt.
Okay. And I just saw a program last night, a really tragic one. And I'm
sure it was on 60 Minutes.
Yeah, you saw that?
Yeah, on the chat.
On the chat thing where this young girl committed suicide, which is not the only one.
Oh, no, right.
But as far as writing papers, there is a problem. And the problem is more at the undergraduate level when they actually write papers. And that is the students are not being challenged enough to think on their own. And if we start losing that ability of our brain function, we are going to have a lost civilization.
Oh, without a doubt.
So there's a real concern. And how do you prevent that?
The challenge is not artificial intelligence. The challenge is human intelligence. That's where we have to be careful. We've got to make sure that we're educating people in a way that they don't lose their brain function.
Well, that's right.
And that's the real danger.
Yeah, there's absolutely.
But that's at every level.
Right. As far as helping, as you mentioned, again, I quoted in one of my papers, there was a study on looking at EKGs. And the AI program was something like 92% picking them out, whereas the techs and docs were about 82%. So, of course, in terms of diagnostic, why would you not want that? We have not actually integrated that as much into the first 2 years. I know you mentioned third and fourth, which is relevant.
Right. We're going to start getting very aggressive because if we need to be current and we need to be a leader in the use of AI in medical education. Otherwise, we're going to be, behind.
Right.
And you don't want to be behind.
Correct.
It's a competitive environment that we're in. So lots of medical schools, lots of osteopathic medical schools, and you want to be current from a technology standpoint. So, we're definitely, going to be on the leading edge. We're not going to be, on the trailing edge of this.
Yep, I agree.
So, Fred, what can I tell you? We've been talking about getting together for a couple of months. So I'm glad we finally put it together for today. Thank you for joining us and for your commitment to supporting the next generation of healthcare professionals. You've inspired growth, curiosity, and excellence through your decades of teaching and research, and I thank you for that. I'm Dr. Jay Feldstein, and this has been PCOM Perspectives.